Ready. So I will introduce myself. I'm a frontline physician who's working in the COVID unit at Eisenhower Medical Center in Rancho Mirage. I admitted 4 patients being ruled out for COVID-19 this week, and one of the first patients I admitted was one of the ladies who died on the ventilator yesterday. I admitted one of the first 2 deaths. As you know, we have a suspicious outbreak at one of our local skilled nursing centers. My background, I am a cum laude graduate of Yale. I did pre-med at Columbia University in New York. I did med school residency and fellowship at UCSF, where I won the Gold-Headed King of the Year and Physician of the Year. I'm an AIDS researcher. Most of my published work is in viral diagnostics. Most of my clinical research is developing new drugs for AIDS, HIV, drug-resistant HIV. I worked at the Gladstone Institute of Virology and Immunology as a pre-med and medical student in a P3 biohazard lab. That's the highest level besides having to wear a spacesuit. So I had to gown up and be in protective gear every day when I worked at my bench working with lethal viruses, and I know them very well. I have done my own back-of-the-envelope calculations based on the best data from Columbia University and UCSF estimates. And over the next 12 to 18 months, if aggressive social isolation with aggressive lockdown conditions like Dr. Kaiser described are not implemented, I estimate that 4,000 people aged 50 or above will die in my valley, and 11,000 of them will require ICU-level care. We only have roughly 65 ICU beds across our 3 hospitals. This is a very serious event. I heard someone say this is a once-in-a-career event. This is a once-in-500 years event. I have told my own family to convey it to a non-scientist that this is something like an asteroid hitting the Earth serious, because all countries are going to be affected and significantly overwhelmed at the same time, which means that us waiting for N95 masks from China or even from Arizona at this point is not going to happen because they're taking care of themselves. I have been very concerned about the exponential growth rate of this, and that's why it's so hard for lay people to understand. In a pandemic, everything is a math formula, and it's numbers. And I've been telling people since February, when I saw the genomics data in Washington State, that we definitely had cases circulating because a lot of the snowbirds that come to the Coachella Valley come from the Seattle region, and they probably had 1,500 people undiagnosed with virus shedding it unwittingly in February. And a lot of those people probably came here. So I already knew that my valley was seeded. I also warned people that asymptomatic persons who don't know they're sick are capable of shedding virus and infecting others. There's plenty of evidence now that I was right about that. I knew that just from the genomics data alone. You can infer some of these things. My numbers that I just gave you of 4,000 deaths 50 and above, it's 200 people dead below the age of 40, and 11,000 critically sick, are back-of-the-envelope calculations assuming no aggressive social isolation regulations are implemented. I am not an epidemiologist. I have some epi training. I did those estimates to paint a picture for policymakers and government leaders. My hospital epidemiologist should have formal epidemiology projections for the Coachella Valley by the end of the business day today, she says. I want to emphasize I do not speak for Eisenhower Medical Center. I speak under my own authority as a licensed doctor with appropriate training. I am a virologist by training and an AIDS researcher, and I have enough epi training to tell you guys what's going to happen. 2 deaths on ventilators at my hospital this week, based on the Italy and China growth curves, which is where we are as the United States, mean 10 deaths on ventilators in a week and 50 deaths on ventilators in 2 weeks. We only have 45 ventilators in my hospital. So when some of you reference the Italy doctors having to turn people away because they ran out of ventilators, that is us in 2 weeks without life and death aggressive quarantine conditions like San Francisco has done. I have been so relieved to hear Dr. Kaiser describe what is intended for the entire county. That is absolutely appropriate. This is an emergency that many lay people cannot wrap their heads around. And the thing with exponentially growing pandemics is they get quiet to overwhelming in the space of as little as 10 days. I have sent Manny Perez a short email with the key resources that someone like me wants policymakers like you to know. He can probably distribute that to all of you so you can do the reading that I think will be quick and concise and tell you the key concepts that you need to understand in responding as non-scientific, non-medical leaders of the community. A few quick points. Almost 500 doctors in the Coachella Valley and their family members have signed a public petition begging for this valley to be put in quarantine because our population is kindling for this virus. We are enriched in people's 70s and 80s, and those people die very well with this virus, and we have a lot of immune-suppressed people, and we know we have a phase 6 pandemic condition here, meaning we have lost containment, we have it circulating in our community, and many people unwittingly have it and are spreading it to friends and neighbors and loved ones right now because they do not understand what aggressive social isolation and social distancing means. In terms of test turnaround as a frontline provider, I can tell you there is a doctor in quarantine from my hospital from our Sentinel event who has not had a test result from the county in 10 days. I know they're working on it, but 10 days is a long time to not know if you're coronavirus positive when you have to send your entire family into exile and live in the house by yourself because you don't know if you can infect them with a lethal virus. Our hospital switched to Quest Diagnostics this past week. We were told a 2-day turnaround, and I can tell you from being on the COVID unit waiting for results that I have 2 patients that are 4 days in, and we still don't have test results. We're going to run out of COVID beds, and so I'd make a strong recommendation to consider that people who are presumed coronavirus while we're waiting on tests, if they do not need oxygen, we create a mechanism to get them safely home so they can isolate in place. People who need oxygen need to be in a hospital. People who do not need oxygen and just need to suffer through this without help can go home and not even eat up a crucial hospital bed. Because in Italy, they ran out of hospital beds because they had so many COVID cases, and as was referenced earlier, your heart attacks, strokes, etc., all still happen, and they need hospital care as well. My hospital offered to create its own independent team of contact tracers for our valley because we anticipate the county is going to be overwhelmed pretty soon if we don't succeed in aggressive lockdown. And we have an epidemiologist who can train them, and we're just waiting for the county to empower us to create our own contact tracers who can report to the county that can do parallel processing because we're going to need all hands on deck. I want to remind people, too, that the test that we use for testing for COVID is not perfect. There are many cases in the medical literature coming out of other countries that as many as 30% of people who test negative still have true viral infection. This test does not have perfect sensitivity, which means that if you test negative, it's suggestive that you're free of virus, but it doesn't prove it. And that means we all have to err on the side of caution and have social isolation. Even my patients that theoretically on the COVID unit might test negative, if they look suspicious and they have a suspicious CT scan, which is a better test to identify cases, I'm not really going to believe the PCR. If my clinical suspicion is this looks like COVID, I'm going to tell them to act like they have it anyway. But the advice to people would be the same. You don't have COVID, isolate in place for at least 14 days and don't go to the outside world unless you must for food. And if you do have it, isolate in place in your home and don't go out to the outside world because you might spread your virus to other people who can get killed by it. We have a materials emergency. The University of Washington is a little ahead of us.
Dr. Loftus, if you could wrap it up, please.
I'm going to wrap it up. Give me just 60 more seconds. We have a materials problem because University of Washington, which is a few days ahead of us, ran out of gowns and masks for their doctors. I have already recruited a team of private citizens to start producing N95 mask substitutes for our doctors in this hospital for when we run out. The state has told my hospital we are the 5th highest priority region, but obviously since we're enriching patients who can die, we're very worried about that lack of prioritization and a lack of urgency. I would suggest that Danny Perez send out to everybody that 5-item email. It can tell you in a hurry everything I would want you to know as a non-scientist governmental leader. But I would suggest that you make a daily webpage for the county that everyone can see with daily updates, maybe multiple times a day updates as to the COVID situation in the county. Because at our hospital, we've been implementing a daily email blast because the frontline providers are in the dark, and that's made our anxiety worse. In Italy and Iran, frontline providers are dropping like flies. Being 20 or 30 years old doesn't save you. New York City has an emergency room doctor on a ventilator right now who is in perfect health at 40, but got exposed to high levels of the virus and is life and death sick. How much virus you get exposed to determines how likely you are to die if you get infected. This is like radiation. Those are my comments.
Thank you, Dr. Loftus. And obviously there's a lot in that. A lot of information, great information. Obviously there'll be some follow-up. Dr. Kaiser, Mr. Barton, Ms. Saruwatari, any comments to what Dr. Loftus mentioned?
Obviously, Dr. Loftus has the advantage of knowing who he's talking about. and then one that has direct access to the outside so that necessary staff can have access to it and ensure that their needs are provided for. There are plans in place for that. Contracts are being determined. I don't have any locations currently, but his point is well taken. It is